Welcome back, guys. This lesson is going to be about the management of acute cholecystitis, and I'm going to go over the fundamentals of the treatment. Now, we know that 95% of the time when there is acute cholecystitis, it's caused by gallstones. There are other cases where you can get acute cholecystitis with no discernible stones on imaging, and this is called acalculous cholecystitis. That does usually happen in elderly people, with those who are critically ill, patients with diabetes, people on immunosuppressive medications for either autoimmune disease or organ transplant. There is a rare case as well of gallbladder infarction, which is a disease, again, of the elderly, as the cystic artery is a true-end artery. If that artery gets thrombosed or an embolus goes to it, it will lead to infarction of the gallbladder. Now, there will be a typical form of presentation of acute cholecystitis that we need to know, which means that the question that we are going to ask the patient will be presented here. Typically, it's a epigastric pain or pain in the right upper quadrant. Sometimes starts epigastric and then moves to the right upper quadrant. Now, characteristics of the pain are important. It's a sudden onset, usually after a heavy meal. The pain tends to be there all the time. It doesn't go. Usually these people had previous attacks in the past, and the pain sometimes radiates to the upper back. We need to check their temperature, and they usually are feeling unwell because of the inflammatory process. But they may or may not have temperature. Also, they will have other GI symptoms, mainly in the form of nausea and vomiting and lack of appetite. We need to understand the pathophysiology of acute cholecystitis. How does it actually happen? People who've got stones in the gallbladder, when the smooth muscles of the gallbladder contracts after a meal to empty its contents, then a stone will get impacted in the cystic duct. These stones are usually small, but larger stones could get impacted in this part of the gallbladder, which is also called the Hartmann pouch. As a result of that, the gallbladder wall will continue contracting, trying to get rid of the obstruction, and that will not happen. Then we will get an inflammatory reaction in the wall of the gallbladder. So in the beginning, it's pure inflammation with inflammatory edema, thickening of the wall. But eventually, bacterial infection will start because of the congestion and the edema that happened in the gallbladder wall. And bacterial infection is what leads to acute cholecystitis, and its systemic symptoms in the form of temperature and raised white cell count and feeling unwell. A little bit about the microbiology that cause the acute cholecystitis. We know that the majority are caused by E. coli. Other organisms, such as Klebsiella proteus, could be there as well. Anaerobic bacteria will occur in approximately 25% of the cases. And in severely ill patients, sometimes that can be caused by Enterococcus. Now, the diagnosis of acute cholecystitis rests on a few things. One of them is the clinical examination. After history taking, then we do some bloods for them, and then we do further investigations in the form of imaging. So it's the same cliche for any condition. that you take history, you examine the patient, you give the bloods, you do the ABCD to stabilize the patient, and then you get imaging. Now, when we examine the patient, they could be a bit unwell. They might have temperature, they have tachycardia. The actual abdominal examination, there would be tenderness on the right upper quadrant and guarding, and also what's called the Murphy sign that you need to practice. We will find on their blood count is that they have raised white cell count in the form of neutrophils. Their LFTs will be deranged. Usually this derangement is mild, and their CRP might be elevated, while amylase is normal. Because if amylase was elevated, then we would call it pancreatitis. We need to interpret the LFTs. So the main thing in this situation is to see whether we are dealing with a obstructive form of derangement or not. And that's by looking at the level of the alkaline phosphatase and the GGT. If they are high, this will give us an indication that there could be a stone in the bile duct. We know that about 10% of people who present with acute cholecystitis or biliary colic, they could have a stone in the bile duct. That's important because if there is a stone in the bile duct, we do not want to miss that because of the complications that would arise from it, which would be in the form of pancreatitis or cholangitis or jaundice. We will see that the parenchymal enzymes of the liver, which is the ALT and the AST, they're usually mildly elevated, and if it is only the ALT and the AST elevated, and that's reactionary as a result of the inflammatory process rather than stone in the bile duct. Now we have examined them, we've taken some blood, and we hopefully got the results of the bloods back. And if we are clinically suspecting acute cholecystitis, first imaging we require will be an ultrasound scan, which is the gold standard for imaging of the gallbladder and the biliary tree as a first line. Now, stones in the gallbladder under ultrasound scan, they will look exactly like that. There's this shadow, a dense shadow, and then the area behind that looks just black because of the no transmission of the ultrasound wave through the tissues past where the stone is. Now, when we do an ultrasound scan, there are 5 notes that I want you to know as essential points to be reported and observed on the ultrasound scan. Number 1, we need to confirm the presence of stones. We need to look at the thickness of the gallbladder wall. So if it is 4 millimeters or more, it's considered as a thickened wall and would be suggestive for acute cholecystitis. Pericholecystic fluid, this will be described by the people who report the ultrasound in the form of what is actually edema in the cystic plate. And the cystic plate is the connective tissue that binds the gallbladder to the liver. So pericholecystic fluid. We need to know the diameter of the bile duct and the normal diameter of the bile duct in a young individual is somewhere between 3 and 6 to 7 millimeters. We consider them mainly dilated if it is above 8, and we get more concerned about stones and obstruction in the bile duct when they are 10 millimeters or over. Ultrasound scans sometimes pick stones in the bile duct, but these stones will have to be bigger than 5 millimeter. Otherwise, they will be missed by the ultrasound. It does mean that the ultrasound is not the right investigational mode for stones in the bile duct. I also need you to be aware that if there are lesions in the liver, they will be picked by the ultrasound, whether an abscess or a tumor or a hemangioma. And also the sonographer will and the radiologist will report to us if there is intrahepatic duct dilatation. Intrahepatic duct dilatation is a very specific sign for distal obstruction, whether it's by stones or by tumors. Now, if you got the ultrasound scan results and also the LFTs, and things are suggestive of a stone in the bile duct, you are concerned there could be a stone in the bile duct. What's the next step to do? The next step to do is to do an MRCP, which is a magnetic resonance imaging. We do that for obstructive pattern LFTs, and MRCP is highly sensitive. It detects about 97% of stones in the bile duct, and that's how it would appear on T2 weighted. This is MRI or MRCP, and it's a T2 weighted image, and the water or the fluid will look like this, and solid material will look like that, gray. So in here there are multiple gallstones, and this is obviously the intrahepatic biliary tree. Now, if these patients prove to have stones in the bile duct, then the first intervention that we would recommend is to get an ERCP, which is an endoscopic retrograde cholangiopancreatography, and that will be therapeutic because then the ERCPs would cannulate the duct and remove the stone by using balloons, baskets, variety of things, and also they will do a sphincterotomy. And this sphincterotomy will facilitate the passage of missed stones or small fragments. ERCP is a great modality for this treatment. It does have its complication, and mainly that will be in the form of bleeding from the sphincterotomy, and the patient could get pancreatitis as a result of the cannulation and manipulation of the duct system. Now, we go a step back that we have the patient now. What are we going to do? We're waiting for ERCP or waiting for further definitive treatment, which will be surgery. We will need to deal with the patient and treat them medically, stabilize them in general for everything if there's any element of hemodynamic instability. Some patients are extremely unwell with that, particularly if they have got empyema of the gallbladder, and they might need even an admission to the intensive care unit if they are too septic. However, this is a very unlikely scenario. So the patient will stay nil by mouth. We give them pain control, which is usually in the form of parenteral opioid. They will need intravenous fluid because they can't eat and they might have been vomiting and dehydrated. And we need to, of course, make sure that renal function, urea, electrolytes are checked. Their sodium and potassium should be known in case they need replacement, or if they are high, they need treatment. Patients will go on antibiotics, parenteral antibiotics, and that would be the rule for any patient who is diagnosed with acute cholecystitis. We usually rely on second-generation cephalosporins. Commonly these days we use ceftriaxone because it's very safe and it's a single dose daily, 1 gram, and relatively cheap. We do need to add anti-anaerobe in the form of metronidazole, and that will be 500 milligram intravenous 3 times a day. There are selective patients who will need that, not every single patient with acute cholecystitis, and these are people with high persistent temperature and they are looking unwell. Patients who are unwell, in particular, they have got poorly controlled diabetes. If their white cell count is quite high, and put our biliary mark here, more than 16, or their CRP is greater than 150, these people tend to be unwell, and we need to add anaerobic cover because the infection is often mixed. Now, the former treatment is mainly preparing the patient for the definitive treatment, and the definitive treatment will be a surgical removal of the gallbladder. And these days we do them in a keyhole manner, which is the laparoscopic cholecystectomy. Laparoscopic cholecystectomy started in 1987 and took off in the 90s, and now it's the gold standard treatment for acute cholecystitis or any cholecystectomy, regardless of the indication. The policy these days is to do the operation on the same admission, and that proved to be more economically viable. The patients will recover quick, they lose less days of work, and also less days of hospitalization. When you are preparing the patient to the operating theater, you will need to do a consent, and you need to be able to explain the operation to them. And in particular, you need to mention to them or emphasize that the fact that there are complications that could arise from the operation. Majority of these operations are now successful in a laparoscopic fashion, and the conversion rate is less than 5%. But there are occasions where the operation turns to be difficult laparoscopically, where we need to convert to open, which is safer in tricky conditions. That's particularly when the gallbladder wall is thickened, and in patients who had previous attacks of cholecystitis and the anatomy is not clear. The main complication that can happen is bile leak, and this is usually from the cystic ducts. Now, the cystic duct get controlled with a clip before we cut the gallbladder, and that clip could be plastic, could be metallic, depending on the availability of these materials. The fact that sometimes the cystic duct could be quite inflamed and friable, the clips could fall off a day or so after the operation, and the patient could leak bile. Bile leak is a serious complication. It's fortunately rare these days, but we need to be vigilant in post-operative day if there is increasing pain or the liver function is starting to become deranged. Pain will be the main indicator because after laparoscopic cholecystectomy, you don't expect the patient to have much pain the day before, and you examine them and you make sure their abdomen is not tender. They shouldn't be tender if there are no complications, because that will mean they will need further treatment. And we will comment on that in later stages, the treatment of bile leak, which include return to surgery and usually ERCP and a stent. Bile duct injury. Now, this is one of the surgeons' nightmares. If they injure a bile duct, we generally feel bad, and we get emotional and take it personally, but it does happen. Fortunately, the risk is very small, and that happens usually in difficult cases where the anatomy is not clear. And the management of that is surgical reconstruction, which is out of the scope of this lecture. Patient could bleed. Any operation, you should inform the patient that bleeding is a possibility. The risk, though, is very small. Another thing can happen is that we could miss a stone in the duct because we do an operative cholangiogram, but we could miss a stone in the bile duct that could lead to complications further down the track. And that's the cholangiogram. This is the instrument that's used for introducing a catheter into the cystic duct, and then we inject contrast media, and then we take X-rays to the patient on the table, and that will give us a lot of details. It will show us the intrahepatic biliary tree, their size, their anatomy, their distribution. It will show us the main duct, and it will show us if there are any filling defects in that, and also we need to ascertain that there is contrast flowing into the duodenum. Now we need to know the complications of untreated cholecystitis. Neglected cases where the presentation to the hospital is delayed, you could get significant complications that would arise from acute cholecystitis. And these can be in the form of impairment of the gallbladder, which is basically a term that tells you the gallbladder is filled with pus. And the patient in that case will be quite sick. Gangrenous cholecystitis. If the inflammation and the infection is severe and neglected without treatment, eventually there will be necrosis of the wall of the gallbladder, and the patient will get sicker and sicker, and they will require immediate attention. There are other things like mucocele of the gallbladder. Now that happens if the patient get acute cholecystitis and the gallbladder is obstructed at the cystic duct or at Hartmann pouch, and they get antibiotic treatment. What will happen is that the infection will settle down, but and the bile will get absorbed, but the gallbladder will continue to produce mucus from its underlying epithelium, and that will lead to what we call the mucocele. If you cut the gallbladder open in these cases, you'll find it filled with white mucinous material. It tends to be painful, and usually the gallbladder is palpable on clinical examination. And the patient felt better, and then the pain, usually they felt better after the antibiotics, and then the pain did not go away, and then they present to the hospital. Now, there is a rare complication of a cholecystoduodenal fistula. Again, this is neglected, long-standing cholecystitis, where we have large stones in the gallbladder, usually bigger than 2 centimeters. That lead to the inflammatory process will lead to necrosis of the wall of the gallbladder, and because the wall of the gallbladder is lying on the second part of the duodenum, the necrosis of the wall of the gallbladder will lead to a pus collection between the two, and eventually that lead to necrosis of the wall of the duodenum. Then a large stone will pass, usually 2 centimeters or bigger, and it will get stuck in the terminal ileum, and that's what's called gallstone ileus. It's a rare condition, mainly in elderly people with neglected recurrent attacks of cholecystitis, which is poorly managed. We often see these days elderly patients, they are sick, they have multiple comorbidities. As the population is aging, we face this more and more, and they are not suitable for an operation that involves general anesthesia and possibly an open cholecystectomy. In this situation, we could temporize the condition by asking the radiologist to do what we call a percutaneous cholecystectomy. So the radiologist will go with the ultrasound scan, see the liver, see where the gallbladder is, and they do the ubiquitous Sildinger technique to insert a drain into the gallbladder to drain the pus. Now this means that usually the patient will improve after that, and that drain will stay after for 6 weeks at least, and then we reassess the situation, and the future management really depends on individual patients.